pleasure to welcome Jamie back to the IUP. She did a master's with us back in the days in MSc Neuroimaging, and then worked with the NetBrain Lab for a little while, and then moved on to UCL to do a PhD, and is now a postdoc. And today she's going to talk about her current and past projects on sickle cell in children.
Yes.
Here you go.
Thank you very much. So I'm going to be, as I said, I was here for my MSc, and then I moved to UCL for my PhD. So I'm going to talk about work I've done in my PhD and now in my postdoc and kind of where we're going from here. So first I'm going to talk about what is sickle cell disease. Why do we care about this? What are the neurological complications? And then I'm going to present some case studies, show you the neuroimaging cognitive profile of these patients, and talk a bit about my PhD work and a bit about my postdoc work, like I just said. So, we'll jump right in. Sickle cell disease is a recessive genetic disorder. It's caused by a single point mutation in the beta hemoglobin gene, which converts a normal hemoglobin A to sickle hemoglobin S. And basically, in red blood cells containing sickle hemoglobin, oxygen transport is compromised. Here's my thing. Did you take that thing?
Oh, it's in the box.
It's in the box. Okay. So, it's okay. In this thing. All right. So, oxygen transport is compromised, and the actual red cells in which contain the HbS molecules, when the HbS molecules polymerize, the whole cell sickles, and that's why it's called sickle cell anemia. And these and these irreversibly sickled cells can't regain their shape even when exposed to oxygenation, and this is basically the whole premise of this disease. So this is a blood slide from 1910, the first described case of sickle cell disease, and so just to point out that we've known about it for more than 100 years now. So sickle cell disease is actually an umbrella term for lots of disorders affecting hemoglobin, are called hemoglobinopathies. The most common and severe is sickle cell anemia, or when the child inherits 2 copies of the sickle hemoglobin gene, but also includes diseases in which hemoglobin S is inherited with other hemoglobin variants, like hemoglobin C and beta thalassemia. In Africa, 400,000 babies are born every year, and in the UK, there are it's about 1 in 2,000 live births, which just puts it over the edge into being officially a rare disease. Down here, this is a really great study from 2010, so 100 years after it was first discovered, showing the, basically on the top here you have the frequency of the sickle hemoglobin allele, and here you have malaria endemicity. So this paper confirmed the malaria hypothesis, which established a very strong geographical link between in these regions. Between sickle cell and malaria, because if you're a carrier of sickle cell disease, so if you're AS, or what they call sickle cell trait, it gives you a natural protection against the malaria parasitic infection. So there's 3 main clinical symptoms, starting from approximately 6 months when fetal hemoglobin decreases, which is protective, and sickle hemoglobin, or hemoglobin A, and most of us, I assume, will start to be synthesized. This is, the first is hemolytic anemia, so abnormal breakdown of red blood cells, leading to lack of normal amount of red blood cells in the blood. Also recurrent painful crises, and vascular occlusion. So there are a lot of factors that go into vascular occlusion in sickle cell disease. We've just talked about the polymerization of the sickle hemoglobin, which leads to these dense sickle cells, which have difficulty circulating the microcirculation. So it's kind of see here, it blocks the microvasculature. There's a lot of molecular factors and platelet activation, inflammatory markers that go into generation of thrombi and contribute to the sickle cells adhering to the endothelium, to the vessel walls, which causes narrowing of the vessel walls, and that's kind of what you can see here. And basically, there are a huge number of clinical consequences that go into sickle cell disease. Just from this factor here, you have retinopathy, osteonecrosis, usually of the femoral and humeral heads, painful vascular occlusion, which is also a consequence of vascular occlusion, very, very related. But also acute chest syndrome, leg ulcers, splenic sequestration, dactylitis, chimerism, progressive organ damage, and cerebral infarction. So cerebral infarction is what I'm going to focus on today, but I wanted to give you an overview of just how devastating this disease is, aside from the brain. So by cerebral infarction, I mean overt stroke, usually always ischemic, but hemorrhagic stroke can occur, cerebrovascular disease, but other neurological complications can include chronic headache, seizures, other types of vasculopathy like moya disease, etc. So sickle cell disease has been called a large and small vessel disease. So overt stroke will occur in about 10% of children in the first decade of life. And silent cerebral infarction occurs up to a third of children. And this is a abnormality seen on T2 weighted MRI in the absence of a focal neurological deficit that would be explained by the lesion. So I'll show you some examples in a minute. But the main hypothesis of why silent cerebral infarcts occur is that you have this underlying anemia, you have hyperemia or elevated cerebral blood flow, dilation of the vessels to maintain the constant metabolic rate in response to the anemia, but also increased hemoglobin S percentage, maybe some underlying vasculopathy, can all lead to increased cerebral blood flow and very poor cerebrovascular reserve. So cerebral blood flow is already at maximum levels. So if there's a drop in cerebral blood flow for any physiological reason, such as compromised cardiac function or acute chest syndrome, or just an increased metabolic demand due to an acute infection with a fever, all these things can lead to, can risk blood supply to the brain. So silent cerebral infarcts have been temporarily associated with clinical events such as an acute drop in oxygen saturation or an acute drop in hemoglobin. So, and it's also important to note that silent infarcts generally always occur in the border zones of the arterial distribution where the flow is most vulnerable. So this is between the anterior and middle cerebral arteries, or between the middle and posterior cerebral arteries in the deep white matter.
James, sorry.
Yes.
Questions. The CVA 10%.
Yeah.
That means these are large strokes.
Yeah.
They're clinically significant. So
Yeah.
the children.
Clinical strokes. Yeah.
Okay, so clinical strokes. Silent cerebral infarctions, 35%. That could be either large or small.
Generally, silent infarcts are thought to be a small vessel disease. Conceptually, small vessel disease. It's not actually characterized as small vessel disease, but it generally doesn't involve large vessels.
So what's the percentage of large strokes that are not reported as a clinically, because you must have that situation as well?
I'm not sure. Usually it falls under the stroke criteria that if there's a neurological deficit lasting more than 24 hours, they'll call it a stroke. But a lot of times there are transient ischemic attacks, and you'll find silent infarcts on the scan, but they're technically silent. They're not silent. They're called silent because they're not an overt stroke. So it's difficult to say. I'll show you some examples.
Sure, but you must have so for example, large frontal lobe strokes that never been reported by. As
you mean large
symptomatic.
vessel?
Yeah, large vessels in the frontal lobe. Children do not report that, do not manifest with any neurological symptoms, and you do an MRI scan and it comes out as big, large stroke that was not reported. So I wonder whether that falls.
That would fall under silent cerebral
Silent.
infarction.
So that's silent. The
Yeah.
combinations of
Yeah.
small and large.
Yeah.
But predominantly, these are small.
Yeah.
That's what it's
Yeah.
Okay.
Yeah. Basically, if it's not labeled a clinical stroke in A&E, it's silent. So, so this is an example of right MCA occlusion in a 19-year-old female. This was a clinical stroke. Her symptoms still last. This was about 10 years ago. And this is the corresponding white matter hyperintensity on T2 weighted MRI. So this is an example of what I mean by clinical stroke. Even though you can see here it's only the white matter and it's not affecting the cortical regions. This is an example of what this is a very, very common example that you see in the silencer bone infarction, where you see areas of small, scattered white matter hyperintensities in the deep white matter, and this would be in the border zone between the anterior and middle cerebral artery territory, and the corresponding hyperintensity on the flare. And these are generally diagnosed as SCI if they're more than 3 millimeters in one direction, but seen on 2 planes of MRI. Official definition. So I'm going to switch gears a little bit and talk about cognition, and more specifically IQ. So the first study that looked at IQ in sickle cell children was in 1963, where they found lower IQ compared to their sibling controls. But it wasn't until the 1990s, when MRI became routinely available to screen for silent infarcts, that you saw this pattern emerge, and it's been shown over and over in the literature that children with history of stroke perform worse than children with history of silent infarcts. Those children with silent infarcts perform worse than those children with sickle cell but have normal T2 weighted MRI, and those children perform worse than controls. So this was a review from 2006, where you see this pattern. You have controls the highest, then those without silent infarcts, then with silent infarcts, then stroke. So I just want to show you, if you're not extremely familiar with the Wechsler IQ distribution. So it's scaled for age or developmental stage, and about 50% of children will, and this is the WISC, so we'll stick with children for now. 50% of children will score between 90 and 110, and that's considered average range. And then you have 110 to 120, high average, superior, very superior, and on the other side, low average, borderline, extremely low. So if you look here at this review, it looks like the control IQ is 90, so that's kind of on the border of average. It's average. And then sickle cell with normal MRI looks to be about 85 in the low average. Sickle cell with silent infarcts about 80, which is here, borderline, low average, borderline. And then with stroke, that looks about 75, so now we're in borderline, low IQ. So I thought it would be a really good idea to repeat this and do my own systematic review and meta-analysis of IQ in sickle cell. So I've looked at all papers that must have included a pediatric sickle cell population, must have included MRI to diagnose silent infarcts, because there's been a lot of papers that don't use MRI, but obviously you'd be, with clinically silent infarcts, you'd be grouping them together, and that's not what I wanted to show. And they must have used a Wechsler IQ scale. So there were 19 studies, and these are the results. So there's a lot going on here, but basically there's 3 comparisons. You have the stroke versus silent infarct group, silent infarct versus no silent infarct, and no silent infarct versus healthy controls. And what this paper found is that there were significantly different mean differences between these groups. So on average, stroke were 10 IQ points lower than silent infarcts. Silent infarcts were on average 5.8 points lower than those without silent infarcts, and those with sickle cell without silent infarcts still were 6.9 points lower than healthy controls. So it follows this pattern reported, and one of the criticisms that I get quite a lot about this work is that, well, you wouldn't think that 5 and 6 points IQ is clinically significant. It doesn't seem like that much of a drop. But if you look at this graph again, if you were kind of here, 90, or even 91, 92, a 5 or 6 point drop in IQ could put you into a lower qualitative descriptive range. And for children who, with sickle cell, who sometimes routinely get tested as part of the school protocol, do this neuropsychological assessment, having them a qualitatively low average IQ can stick with the child and create this cycle, which unfortunately happens. So regardless, 5 and 6 points lower. But what's really interesting here is what is the link between silent infarcts and IQ? So all these papers looked at kind of a binary factor, either you have a silent infarct or you don't, but surely there must be more to that. What about the size of the lesions, the distribution of the lesions, where it affects in the brain? All these things have got to be really important, so I'm going to get to that in a minute. And most likely there's a threshold of volume before IQ is affected. And another thing that comes out of this paper is, well, what's the difference here? There's no abnormality on MRI, so why would there be 6.9 points lower than their sibling controls? What can we tell about the brain that might explain these differences?
Jamie, sorry.
Yes.
You reviewed the literature, so
Yes.
usually there was a sort of age, that 7 years, that people think that if you had a brain injury before 7, it was better because then the brain could recover better in the contralateral hemispheres. After the age of 7, this recovery and compensation is more difficult. So you reviewed the literature, and I was wondering whether that you have a feeling, if there are longitudinal studies that looked at, for example, whether these small differences at the age of 5, for example, in the IQ, would make a big difference over time, and whether that there is a crucial age where actually these differences become significant.
There's only one study, to my knowledge, it's a longitudinal IQ, and that looks at children who were about 8 when they started, so that doesn't really answer the question, but it seems to have consistent results. Those children at the lower in the beginning stay low as they get older.
And the gap is the same or actually increases?
I'm not sure. I think it's about the same, because I think they kind of went on similar trajectories. But when you're talking about the age of insult to the brain, we know about the stroke group, although these studies don't report the age in which the stroke occurred. The SCI group, it's completely unknown, because we have no idea when they're clinically silent. So it's very difficult to tell. There was a really good study that they've looked at in response to these acute events. They looked at hospitalizations and scanned them and found acute DWI positive lesions that sometimes progressed into silent infarcts and sometimes didn't. So it seems like it's this constant hypoxia that's causing these silent infarcts, but it's no way to tell when they've occurred.
Their IQ assessment has been done at a certain age, each study, so they've done the same.
But we don't know what the age of injury is. So we don't know what happened when they were assessed, how long.
But you could stratify your studies and saying, for example, when IQ has been assessed at the age of 5, we do see significant differences between the different groups.
Yeah, they've shown differences in developmental delay as young as 9 months.
Okay.
So it seems to be. That's a good thing. We should look at it. Where am I? Okay, so switching gears again, I want to talk about these lesions, and I want to look at 3 cases that look at the distribution of the lesions. So this is case 1. This is a 12-year-old male with homozygous sickle anemia, history of transient ischemic attack when he was 5, 6, and 8 years old, but no history of clinical stroke. So if we're looking at this, and if you see anything abnormal, maybe about there, you'd be right. So the radiologist would say scattered bilateral frontal and periventricular white matter lesions, and that's where it would end, generally with the radiologist's report. But what we can do, which we're collecting as of now, is a 3D isotropic flare, so we can actually trace these lesions in high resolution. And this is what we'd look like when we, together with the radiologist, approves that these are, in fact, areas of abnormal white matter signal. And what I've done is I've registered these images to MNI space, so this is what the masks look like in common space. And I've used this program called Tractotron, which probably a lot of you are familiar with, which, in case you're not, it uses published white matter atlases to to determine a pattern of disconnection that would be of white matter tracts that are induced by these lesions. So when I run it through Tractotron, with greater than 50% probability, these white matter lesions in this patient would affect all of these tracts. So we have a pretty substantial list here. Anterior thalamic radiations, the cingulum, corpus-spinal tract, the frontal ascendant tracts, perilongical fasciculus, 1 and 3, frontostriatal, inferior frontal occipital fasciculus, pons, anterior fasciculus, corpus callosum, and then most of them also on the right side. What Tractotron also gives us are these probability of disconnection maps. So with greater than 50% probability. So here, these are thresholded. So purple would be 50% probability, where yellow to white is closer to 100% probability. And you see from these lesions quite a lot of involvement in the anterior corpus callosum and the bilateral frontal lobes, extending all the way superiorly. So if you would guess from what I said before about children with silent infarcts and IQ, and looking at these maps and what you would expect from their cognitive profile, perhaps would be somewhat impaired, maybe? No? Okay. Well, if you thought that, you'd be wrong. Because in terms of the WISC IQ, this child scored high average, or an average range across the whole board with a full scale IQ of 109, which is average, very good. Average score on executive function, which I was not expecting given the frontal lobe, nature of his lesions. Average to above average scores on visual and verbal memory. And these are similar to reports that he had in 2011 and 2009, which he's had through school assessments, where he's scored average to high average on those as well. This is the behavior rating inventory of executive function, which is a parent questionnaire about the child's behavior at home, and where in the blue would be kind of problem areas, and seemed fine. So this is an example where you can't assume that just because they have a silent infarct, anything necessarily would be wrong. Let's look at another case of a 16-year-old female with history of recurrent painful crises and back pain. She was found to have small microinfarcts on her spine. Previous history of collapse, and history when she was 9 years old in school, difficulties with attention, concentration, and executive function. So this is her T2-weighted MRI, and the areas of abnormality are here. You can see them. And again, scattered small white matter signal changes in the frontal and parietal lobes. Probably the biggest one here, starting kind of here and going this way. So this is what it looks like when we've traced it on the flare. And this is what our lesions look like when registered to MNI space. So a lot of bilateral frontal and parietal infarcts. And again, very similar, when we ran it through Tractotron, very similar profile of disconnection of white matter tracts. Except this time, it looks like it affects the arcuate, all tracts of the arcuate fasciculus on both sides. So this is what her probability of disconnection map looks like. So different colors, but exactly the same kind of theory, where dark blue would be 50% probability, and green, bright green, would be closer to 100% probability. So again, a lot of bilateral frontal involvement and this deep white matter of the centrum semiovale extending superiorly. So given that, do you have anybody have any guesses of what might be affected in this child? Maybe? No? Well, again, average to low average range, low average in perceptual reasoning. Maybe you can contribute that to the visual spatial networks of what we see in the disconnection, but full scale IQ of 94, so average. Her mother reported that maybe some problems with inhibition, initiation, working memory, but that's a parent questionnaire, maybe. I don't know how valid that is. It's important to know that she missed 70% of school in the last year due to sickle cell-related illness and pain. So that's another important thing that goes into your IQ. But again, another example where the distribution of the lesions doesn't really account for IQ, lowered IQ. Okay, third case is a 21-year-old male with sickle cell anemia, and he's been coming to our institution for the past 15 years, very heavily involved in research. He would be scanned every day for the rest of his life if you asked him to. He loves coming in. As you can see here, he's got some pretty prominent white matter signal changes in the right frontal lobe, bilateral frontal lobe there. These lesions on the right frontal lobe is from a clinical stroke when he was under 5 years old. His symptoms resolved very quickly within, I think, 36 hours, but technically labeled a stroke. And these in the left frontal lobe are likely silent infarcts that have happened over time, but have no idea when those occurred. So a lot of extensive right frontal lobe damage going on here, white matter damage going on here in the flare. And then this is what his lesion looks like on the M&I space. And again, going through tractotron, we find frontal lobe white matter pathways affected here: corpus callosum, anterior thalamic, cingulum, frontal striatal, inferior frontal occipital, superior nodular vesicular. So it's a very similar pattern we've seen in the last two cases as well. This is his probability of disconnection map, where, again, orange would be 50% probability of disconnection, where white would be more like 100%. And it looks like anterior corpus callosum is very affected all the way superior through the brain. So, again, if you thought about what I said about stroke patients generally in the meta-analysis and you look at this disconnection, you might think, but thinking about what Marco said about age of insults, maybe this is kind of going along with what you said. So he has an IQ of 100. Couldn't be more average than that. He has above average performance on the Wechsler memory scale, auditory, visual, immediate, and delayed working memory, delayed memory and working memory. Average score on the executive function task. So very average. You know, it's very difficult to tell. So these case studies show that there's a huge, huge range in cognitive outcome, even when you've had these insults. So I tested him in 2011, where he had a full scale IQ of 108. That was from the Western abbreviated scale of intelligence, so not exactly the WISC or the WACE. But you can argue that maybe there's a decline, but I wouldn't call an IQ of 100 in any way impaired. So just stay with that. So, huge variability in the severity of disease and cognitive outcome, which I said before. And the link between silent infarcts and IQ is unclear. So there's been a paper that showed there's a threshold of lesion volume before cognition is affected. They kind of took the patients and stratified them between small lesion volume and large lesion volume just based on the median of their 10 subjects. And the ones with large lesion volume had lower IQ. There was a paper from this year that looked at the volume of white matter hyperintensities and found that it was an independent predictor of IQ and processing speed. But again, with both of these studies, I have a big problem with people tracing lesions on 5 millimeter thick slices with a 3 millimeter slice gap. So we can take these are published work, I'm sure they're good, but I'd like to recreate that using a more robust technique, I suppose, and a 3D isotropic sequence. Anyway, what's even more important than that is what I hinted to you before about the second child missing 70% of school, is that IQ is much more likely to be related to environmental factors. These children are ill, sometimes chronically ill, they miss a lot of school, they miss a lot of, they're always in hospital, they're always in pain, so that plays a role in school performance and which likely affects their IQ. So this SIT trial was the silent infarct transfusion trial, which just finished this year, where they looked at blood transfusions as therapeutic intervention in 200 patients with existing silent infarcts to see whether or not blood transfusions would limit progression of cerebrovascular disease. It turns out that it only limits progression of future overt stroke, not silent infarcts. But the point of the trial, well, the point of this study, was that they found in these 200 children, parent education and socioeconomic status was the biggest predictor of IQ, not any hematological or neurological variables. So we have that to do. So switch gears again and look about what about the children with no MRI abnormality? Well, in terms of MRI, there's been a couple studies looking at cortical thinning and widespread in all 4 lobes. There was a couple studies that looked at volumetric deficits of specific subcortical structures. And then there's was a really nice study looking at white matter density decreases using voxel-based morphometry that found white matter density decreases in this border zone distribution of the between anterior to posterior, superior to the ventricles. And that's exactly where you find these silent infarcts. And these were in children without any MRI abnormality. So there must be something going on that we can quantify under the radar of conventional T2-weighted MRI. So I want to talk about this study that was published this year, where I looked at 25 patients with no abnormality on T2-weighted MRI and 14 sibling controls. And we used a diffusion tensor imaging track-based spatial statistics study, which looks at the whole brain voxel-wise analysis, looking at this green white matter skeleton here. And what we found is that fractional isotropy was lower in patients, mainly in cerebellar white matter. And mean diffusivity and radial diffusivity was significantly higher in patients in very widespread areas, both in the cerebellar internal capsule and the deep white matter and anterior cerebellum. So very widespread global changes here. Further, we looked at the correlation between daytime oxygen saturation and hemoglobin with these variables, and we found significant negative correlations between radial diffusivity and oxygen saturation in the anterior corpus callosum, and significant negative correlations between radial diffusivity and hemoglobin in the posterior parts of the corpus callosum. So these are the correlations, and it's important to know that these correlations are just from this cluster of significant results here. It's not across the whole brain, but just show you some pretty good correlations there. Okay, so that work kind of led me to where I am today. So in my postdoc, which I've started this year, we're looking at 2 different trials. One of them is a follow-up of a clinical trial called SAC, which was the sickle cell anemia, sleep, and asthma cohort study, which looked at children with sickle cell anemia, but also with underlying respiratory problems, such as asthma, sleep-disordered breathing, unexplained chronic nocturnal hypoxemia, etc. And this was an observational trial that went on for 9 years, looking at the relationship between sleep oxygenation, lung function, and pain. So now they're back at our institution, and I'm recruiting now, and the 3 patients that I showed you are 3 patients that were in that trial. We have a whole host of sequences, high-resolution anatomical sequence, diffusion tensor imaging, multi-shell diffusion tensor imaging, arterial swim lane lengths, and of course a very comprehensive neuropsychological assessment. And then the second project that I'm working on is a prospective clinical trial called the Prevention of Morbidity in Sickle Cell Anemia. And these is open to children and adults, and they are screened for an abnormal sleep oxygenation. So if you, at any point during sleep, your oxygen saturation goes below 94%, you can be in this trial of 6 months of overnight oximetry support, which is using automatic positive airway pressure masks, which is like a mask that you'd wear for obstructive sleep apnea. And the main outcome measure of this trial is actually cognitive. We want to see whether or not the 6 months of treatment will improve processing speed and attention, but also we're scanning before and after 6 months to look to see whether or not there's improvement in this radial diffusivity, which seems to be related to the oxygen saturation, and also increases in hippocampal size, which has been shown in adults with obstructive sleep apnea using the same intervention. So that's where I am, and that hasn't started yet. Well, we have one subject, so not yet anything to say. And that's really it. So I'd like to thank people in my section, my professors, funding for my studentship, and the funding for my postdoc, and our wonderful research radiographers right on the street. Thank you.
Are there any questions?
I have one question.